at the MIC meeting, I participated in a debate after a presentation on refractoriness to lenalidomide and retreatment in especially second line. The presentation was one presentation from me and one from Xavier Leleu about what options we have in second line treatment. And the difference now from earlier on is that we see that more and more patients are refractory to lenalidomide, especially when it comes to second line. We have for many years based our second line treatment on lenalidomide, but now with many patients using lenalidomide in first line and continuously, both as maintenance treatment and as continuous treatment, many patients are refractory to lenalidomide when they come to second line, and we need new options for them. And there's also recently approved 3 regimens in first line, both for the young and for the elderly, with daratumumab in first line treatment. And so some patients will also be daratumumab refractory when they get to second line. So at the MIC meeting, me and Xavier Leleu discussed the options you have in this situation. What treatments would you give in second line if you are refractory to lenalidomide, for instance? And we agreed quite much on this. And I think the patients who are refractory to lenalidomide, they do have several options in second line. From some years ago, we have the opportunity of using pomalidomide, Veldex, the Velcade, the dexamethasone. We also had the possibility of using carfilzomib, dexamethasone. But recently, last year, 2 new regimens were approved. That was isatuximab in combination with carfilzomib dex, or daratumumab in combination with carfilzomib dex. And these 2 treatments we agreed that these 2 regimens are now the standard of care in patients that are Revlimid refractory. They have definitely the best PFS in the situation of patients in second line. There's also a change of mechanism where you go from an IMiD and you go to adding both a CD38 and a better proteasome inhibitor than what we use in first line, which is the Velcade. So it's quite clear that the standard of care in Revlimid refractory patients now is daratumumab, carfilzomib dex, or isatuximab, carfilzomib dex, whichever you have reimbursed, if you have any of them. Of course, there are still many countries that do not have any of these options available in second line, but this is today the best treatment. So the kind of more difficult situation is if you have patients who are also refractory to daratumumab, which is approved in first line. So these patients, if they are refractory to both daratumumab and to lenalidomide, the options in second line is probably the best options now is to use the combination of pomalidomide and bortezomib dex, and because then you get to use both the proteasome inhibitor, because many of those who are refractory to both regimens now have used daratumumab Revlimid in first line, so they haven't seen a proteasome inhibitor. So for those patients, pomalidomide Velcade dex is probably the best option. There's also an option with selinexor bortezomib dex, and the data are quite similar. I think we kind of didn't agree as much on this because it's a bit difficult to know, but if you want to choose between the regimens of pomalidomide Velcade dex and selinexor Velcade dex, it's a bit more difficult because patients who are refractory to an IMiD like lenalidomide, you would maybe want to prefer to switch them to something completely different like selinexor. On the other hand, the data for selinexor pomalidomide dex is not better than pomalidomide Velcade dex, and selinexor is maybe a little bit more toxic. So, but these are 2 options that are available for in that situation. And if we could choose from things that are not approved, we would also like to consider carfilzomib pomalidomide dex, but since especially in Europe, since there is no phase 3 data on this regimen is not available. So I think in most cases it will be pomalidomide Velcade dex in this situation. So you have come to a new situation in myeloma where the new regimens in first line are changing what we need in second line. But on the other hand, we have received new second line options like daratumumab, carfilzomib dex, and isatuximab carfilzomib dex, and also pomalidomide veldex. So altogether, it seems like there are good options for these patients also. And we have to remember also that even though patients who are refractory to Revlimid do have a worse prognosis than patients that are not refractory to lenalidomide. They are refractory because they have used it for a long time, and the median PFS of the Dara-Lendex regimen is about 4 or 5 years, maybe even more. So they have already received a large benefit from using these drugs before they get to second line. So all in all, these are great improvements for patients with myeloma.